This is the Shift Shapers Podcast, connecting benefits advisors with thought leaders and entrepreneurs who are shaping the shifts in the industry. And now, here's your host, David Saltzman.
You know, whether it's because we've been quarantined and we're used to having things delivered to the house, or whether you're in my generation, the boomers, and you want to control your entire universe and you've decided that things ought to come to you, you can go out when you want to or whatever. There's been lots of change, and there are more and more services that are being delivered directly to you. I tell people that one of the reasons that I chose to move to my new home is because I'm the world's oldest millennial, and I like having everything delivered and at my fingertips 24/7, 365. But that hasn't been the case with medical care, at least with most medical care. I mean, we've had telemedicine, but that's not the same as having something in person. And so we thought that would be an interesting discussion, and we invited John Young, who's VP of Growth at Nice Healthcare, to join us because they've kind of got a different take on how to deliver healthcare, and we thought it would be interesting and you know, maybe instructive for everybody. So with that, welcome, John.
David, thank you so much for having me. Excited to be here.
It's our pleasure. It's our pleasure. So let's talk about this fact that you guys call yourself a clinic, and clinic sometimes has a negative connotation. But clinic in your sense is a little bit different, isn't it? You kind of reimagined that.
Yeah, that's right. I mean, we have designed what we think is a completely different take on how primary care is most effectively delivered, but we're borrowing some of the same vernacular and some of the same terminology that patients are used to, because it's important for us to communicate that even though we use slightly different modes of interacting with our patients, whether it's virtual visits or if it's sending providers into the patient's home, we really are able to conduct a wide array of services using those means of communicating and interacting with our patients. And so the scope of service that we're able to provide is much more akin to what is found in a traditional clinic setting. So that's why, attaching to that connotation of clinic is something that we've been intentional about.
Who are the patients demographically? Who are these folks and what's driving this?
Yeah, right now, our patients are normally employees of employers who have chosen to provide a unique access point for their employee base as a way to attract and retain awesome people, but also as a way to help control healthcare costs. And so our patients today are typically employees of small and medium-sized businesses who have decided to interact and to engage with our clinic because it provides more convenience and it provides more affordability in how they're pursuing their primary care needs.
So this is a primary care type relationship like you might have with a DPC clinic?
That's right. Yeah. So we operate much more akin to a direct primary care clinic, meaning that all of the services that we provide are covered under a fixed capitated rate. And so this is compared to the traditional kind of fee-for-service mentality where clinics are coding individual services or procedures that are conducted during a particular visit, and then that's how they are reimbursed. And furthermore, that's how patients are charged. We operate more on a fixed capitated rate to provide unlimited access to all of the services that fall under our scope of service.
So, but you're sending folks out to see people in their homes, by and large. How can that be more cost effective for an employer? Because everybody's watching costs today.
Yeah. So when we designed our clinic, we made the decision to structure our operations differently than traditional primary care, and there were really three big bets that were part of that allow us to deliver more affordable care despite providing what some people view as more concierge level of service by sending actual providers into the community, into the home. The first is that we don't operate any physical bricks and mortar clinic locations. So we don't have that overhead expense that we're looking to support and to offset that type of a cost. The second thing is, by virtue of being a direct primary care clinic and not submitting claims through an insurance vehicle, we're able to knock 25 to 30% off of our cost structure by just not having to deal with a lot of the administrative work that comes along with being an in-network provider with an insurance type of arrangement. And then the third important piece about how we're structured is that we're a nurse practitioner-led clinic. So the day-to-day care that's provided at NICE is done by a team of NPs and physician's assistants who have made the conscious decision to come over and to join our model. But those three decisions in combination allow us to go out at a price point that continues to be affordable for our members, but that doesn't sacrifice in areas of accessibility, convenience, and scope of service.
Now, I know one of the things that folks who like a direct primary care type practice, myself included, that you get 40, 45 minutes more if you need it with whoever your provider is, whether it's at the NP level or at an MD level or whatever. Is that the same thing that you guys are delivering? So has that changed from a more traditional DPC bricks and mortar relationship, or is it about the same?
Yeah, so under our model, we budget 45 minutes of time between a patient and provider for all the virtual visits that we do, and we budget an hour and a half for all of the in-person visits that we do. And we do that because of two reasons. The first is that it provides ample time for our clinical team to get to the crux of the issue with a given patient, provides the time to develop the relationship, and to really get to the core of what is driving that person's individual health status. And so we want to provide that time for our clinical team to do our thing, but we also provide that time then to give the patients the ability to be open with their provider and to not feel limited both in terms of time, but to also not feel limited in terms of the types of things that they can address and to raise with their providers, because they understand that is not how that they're going to be billed on the other side of this visit. So by providing that longer period of time for our clinicians and our patients to be able to interact, we believe that it both empowers our clinical team as well as for the patients to really put it all on the table and to have a more effective visit during that time spent together.
Well, I know that one of the things that drives cost in traditional practices is the amount of referrals to specialists that happen. Independent practices not in the DPC mode where they take a broader view of the patient. They call it the old phrase that we used to call it medical home when it was first developed. Do you find that you're referring as much as a traditional practice or less than a traditional practice? And what does that do to the overall spend?
Yeah, so our referral rate as a clinic is incredibly low. We run at about a 3% referral rate. So 3% of the visits that we're conducting, require some sort of referral out to a specialist or something that's outside of the scope of our service. But what we're trying to do at NICE is to try to continue to expand our definition of primary care and to include more and more services under the umbrella of what our primary care clinic is capable of handling, so that we can keep the referral rates low and so that we can prevent unnecessary referrals when needed. A good example of this is introduction of physical therapy. January 1st of 2021, we introduced access to licensed physical therapists as part of our platform because 30% of the visits that we were doing involved some sort of musculoskeletal complaint. And so by introducing access to PT, we've been able to reduce our referral rate for that type of care. And so I think what we'll continue to do as a clinic is broaden our definition of primary care through things like mental health, for example, where we are able to extend our services beyond traditional primary care and bring it more into the specialty layer, whether that's providing access to therapy or some other more involved types of care for our patients.
Is there a role in the kind of practice that you guys are developing? And I'm fascinated about it because it's I haven't heard of anybody else who's doing kind of what you guys are doing. And it as somebody who's boomer enough so that I remember, house calls is what we used to call them when the doctor would get out of his car with a little black bag and would come and see you. Do you find that you're also using technology like telemedicine and whatnot to augment the in-person visits, or are you straight in-person visits?
Yeah, so telehealth is in the virtual layer, whether it's chat visits or video visits, is kind of becoming table stakes, I think, for what most clinics are able to offer to their patients. But what technology is really enabling for us is to be able to conduct more care in the home and not sacrificing, any of the patient experience of what they would have otherwise had to, receive in a bricks and mortar location. Good example of this is, being able to do in-home blood draws or being able to do in-home X-rays or EKGs. That wasn't possible 25 years ago. And now today, a clinician can show up with essentially a piece of equipment that mimics a small suitcase, and it's a mobile imaging machine. And we can go in, we can get a view of a sprained ankle, or we can get, an EKG to take a look at that heartbeat. And that's because the technology is enabling it. And I think what we're going to continue to see is the clinical team that is out in the field and going into the home is going to have more and more tools that enable them to get a perspective on what that particular patient is dealing with and inform the care pathway, and not necessitate that patients travel into a clinic location to have certain labs or testing done.
A couple of years ago, we interviewed Dr. Samir Kamar, who's got a device called a MedWand, and it looks, for lack of a better description, like a pregnant mouse, which is his description, not mine. But it allows the physician on the other end of the call, this is a patient-used device, and it allows the physician on the other end of the call to get so much more information, real telemetry, real data. It can, look in your ears, it can look in your nose, it can give you not EKGs, but a pulse rate and heart rate and all that kind of stuff. Are you guys incorporating those kinds of technologies into what you're doing? Or do you plan to?
Yeah, remote monitoring, the ability to transmit data, from the bedside or from the home to a clinic or to a provider that is located somewhere else. That's continuing to become more commonplace. We have some cool things going right now in the area of diabetes, where patients are going to be able to monitor glucose and A1C levels from home and transmit that information to a clinician to help inform their care, and to do that remotely. So the answer to your question is absolutely. And that's where this convergence of everything that's happening with all these smart medical device companies, innovative companies that are looking for ways to, improve communication and remote monitoring between a patient and a clinician. It's incredible to see the amount of progress that's being made there.
Yeah, it's really interesting. And so many things have happened in the last year and a half that have kind of, as I said in the open, have fostered that notion of there's got to be different ways to deliver healthcare, and there's got to be ways that are easier and that take advantage of all this great technology that's surrounded us for years, but hasn't really been embraced by the medical community because the same old model has been the same old model. Yeah. Speaking of technology, obviously there are times when you refer, and there are times when people end up hospitalized and having major surgeries and whatnot. As you see patients, what kind of an EMR are you creating that can then be transmitted over to a hospital or an insurance company if they pierce that threshold of primary care and they end up having to see another specialist on their med-surg plan?
Yeah, so specific to electronic health records, we ultimately made the decision that we were going to create our own, because we couldn't find anything off the shelf that was that was appropriate for how we were organized as a direct primary care clinic, and we wanted to be able to build something up from the scratch that was most conducive for how we approach patient care. So we made that investment, and is a tool and is an asset for our clinical team to make sure that we are documenting and that we are sharing information about a patient across our entire clinic and doing it as effectively as possible. That extends, David, to other primary care providers or other specialists who want insight into what type of activity we're conducting under our purview. So we can send a patient's chart to another provider, to a specialist, to make sure that nothing is being missed and that those other care providers are getting insight into all of the things that are happening under our purview. But that transfer of information goes both ways. We are also set up to take that information in. So if a patient is seeing an endocrinologist to help them manage their diabetes and wants that information that's in that chart to inform our decision making as their primary care provider, all it takes is a simple request for the patient to have that information sent over to our clinic, and it happens. And so that process is something that's really important to make sure that there's continuity of care between patient and all the different providers that are seeing that individual.
You mentioned earlier musculoskeletal and PT. The other big driver, of course, is pharmacy.
Yeah.
What's happening in the pharmacy realm? How do you approach that with these patients?
Yeah, I think there's two categories of medications. There's the cutting edge specialty type medications, brand names, ultra expensive, treating ultra complex and important conditions. And then there's your nuts and bolts medications for the most common, acute illnesses as well as chronic conditions. And in that latter category, we've chosen to get pretty aggressive on removing barriers for our patients to having access to those types of medications. So what we chose to do is we designed a formulary of about 550 medications across both acute illnesses and chronic conditions that, when prescribed by one of our clinicians, are available free of charge to our members. And when we made that decision, we did it because we are trying to help improve adherence on some of these core medications that are critical to helping our members achieve positive health outcomes. And so while some people might think, that a $10 or a $20 prescription isn't cost prohibitive in their personal case, for a large portion of the population, like that's material. And so we made an investment in building that into our core offering, so that our members don't have to think about it. So that if that we don't want them making a decision between taking one of their core medications to help control blood pressure, and not taking it because they don't have the money. We don't want that decision to be on the table for our members.
So is the formulary largely scaled around ongoing chronic conditions and the management of those?
There's a large majority is focused on chronic conditions and those types of diseases like a hypertension. There's some for depression, anxiety. There are some for cholesterol. A number of chronic conditions, but there's also those for the acute illnesses. The chronic, the more common ones like antibiotics. For the strep throat type of thing. The ointments for rashes. So it's a combination of acute illnesses and chronic conditions.
We've only got a couple of minutes left, and I'm always interested in how people who are doing cutting edge things see the future. What do you see happening in the near and long term in terms of this kind of care and this kind of practice and its adoption on a wider basis?
Yeah, I think, when we talk about continuing to expand the scope of service and the type of care that can be conducted in a home, that is going to continue to evolve. You see healthcare systems now making an investment and not just being able to provide, core primary care services in home, but basically, turning a home address into a quasi-hospital room by shifting more and more involved care and monitoring outside of traditional venues and into the comfort of an individual's home address. So I think as technology continues to develop, that small percentage of primary care that still requires patients to travel into a clinic is going to continue to get smaller. And for us, that's what we're most excited about, because the more that we can help treat our patient population and the more conditions that we can address through the advent of technology, we're just going to be able to provide an even better experience for our members, and that's really all we're trying to do.
Now, one last thing just for all of our advisors who are going, wow, I'd really like to talk to my clients about this. You guys are not yet nationwide. Where are you now? Where are you going in the near term?
Yeah, right now we're licensed in 10 states at the time of this recording, and here we are in the spring of 2021, and that list of markets that we're operating in continues to expand. We have a footprint in Minnesota and Wisconsin and Nebraska, Utah, Arizona, Colorado, and that continues to grow. And so we'll continue to look for new markets that where our model fits really well. We look for states where there's DPC laws that are on the books and places where nurse practitioners can practice at the top of their license, meaning that they can prescribe, and they can diagnose, and they can treat with full autonomy. And so those are some of the things that we look for in the attractiveness of the new markets that we're considering.
If you're interested in getting in touch with John, just click his logo on the ShiftShapersOnline.com page, and you'll be able to reach them. John Young, Vice President of Growth at Nice Healthcare. John, thanks so much for sharing some really exciting new motifs for delivering treatment with our audience.
David, thank you so much for having me. Really appreciate it.